Let's go back to 1980. A 55-year-old man comes into my office with a 3-centimeter mass palpated in the right lobe of the thyroid, sent by his family doctor. There were no risk factors, no compressive symptoms. Exam was negative, vocal cords mobile, TSH normal. An ultrasound showed a 3-centimeter mass with no other features of note. Nodes were negative. He may or may not at that time have had an FNA. FNAs were not prominent. We use clinical factors to justify whether he had surgery, whether he should have surgery or not. So there was age, gender, and a solitary mass. Good reason for surgery in those days. He would have had a total thyroidectomy. He had a 3-centimeter papillary carcinoma with no adverse prognostic features. In those days, there were no standardized synoptic pathology reporting. He would have automatically had RAI, and his follow-up would have been varied. Some people would have just done a physical exam, some an ultrasound. There were no biomarkers in those days. He may have developed a paratracheal node, which may not have been detected, and his outcome probably would have been great. Fast forward, same patient, a 55-year-old male again, had a routine ultrasound because of neck pain. Isn't that why you do ultrasounds nowadays? And this time, he may have had an ultrasound-guided fine needle aspirate for his neck node. If it was atypical, he may have had options to go on to molecular testing. If it was malignant, he would have had less than a total thyroidectomy, according to most guidelines. And his pathology in a synoptic report would have been reported as papillary thyroid cancer, and he probably would not have had radioactive iodine. We'll go on to see why. He would have been staged in a 3-part fashion. He would have had a TNM AJC type of staging, a stage 1, where his disease-specific survival would have been 98 to 100%. His ATA risk for recurrence would have been low, and his ATA response to therapy would have been excellent if his TG were undetectable and there was no anatomical evidence of tumor. Therefore, no completion thyroidectomy. He would have been followed with serial ultrasounds and thyroglobulin if a total thyroidectomy were done. And perhaps if a paratracheal mass were found, say 1 centimeter, he may have had an FNA that found PTC, but then what?